Done. The first patient is a 52-year-old gentleman who presented with blurred vision in both eyes of 4 months duration. He had no other significant ocular or systemic history. He had a best corrected visual acuity of 618 less than N36 in both eyes. The anterior segment and the intraocular pressures were normal. The dilated posterior segment showed this picture. A bilateral central serous retinopathy with some amount of fibrin. Also, the flavor of the morning seems to be central serous retinopathy today, but I can assure you the remaining two are not CSRs. So this was the picture in both the eyes, and this was the fundus fluorescein angiogram showing multiple PEDs in the right eye as well as the left, and some points of leakage as well. We explained the diagnosis to the patient, and the prognosis was explained, limited treatment options, and the variability of visual results with laser treatment was also explained. We did take a history of any oral drug intake in the form of oral steroids, but there was nothing forthcoming with that as well. He presented 10 days later as he was contemplating on what to do, complaining of further drop in vision. And at that time, the situation had worsened, the fluid had increased, and he had inferior detachments as well in both the eyes, with an increase in the fibrin, subretinal fibrin as well. The question was, what next? I accidentally happened to notice this in his shirt pocket, and I asked him whether he had been using this. He had been a chronic smoker, he was a chronic bronchitic as well, and he said some friend of his told him that this would give relief, and he had been using this right, left and center without any supervision. And we discussed this issue with his chest physician and switched over to non-steroidal drugs. And lo and behold, 3 weeks later, this is the fundus picture of this patient. And the inferior detachments also had settled down nicely, and his systemic condition also seemed to be better with the other immuno. Decrease nitric oxide in the local milieu, which is a natural vasodilator, delays RPE healing, which may occur from whatever reason. And also it alters the RPE polarity. These are some of the mechanisms by which steroids induce subretinal fluid accumulation. Rarely bilateral CSRs may be related to Cushing's syndrome. Changing to other antihistaminics and immunomodulating drugs, and even a decrease in the dosage of steroids, if it can't be completely removed from the treatment, often aids the resolution of CSR. So the take-home message was, even a steroid that is being taken for nasal allergy or skin ointments being used for the patient for some skin ailments have been reported to cause central serous retinopathy. One should be cognizant of these facts. The case 2 is intriguing one even at the end, so I would like your inputs on this. This is a 28-year-old gentleman who presented with blurred vision in the right eye, 2 months duration. There were no other associated symptoms. His vision was 624 parts N8 in the right eye. He had an RAPD. The rest of the findings were all normal. And this was the fundus picture in the right eye. He had this whitish cobblestone-like looking appearance in the macula, and also in the nasal and the superior aspects. Almost the whole of the posterior pole was looking somewhat pale, but not uniformly pale, but somewhat it had a nodular looking appearance. The left eye was normal, and these are the angiogram pictures. You could only see the silhouette of the retinal vessels against the background of a faintly appearing choroidal fluorescence. Even at 34 seconds there was no dye in the eye. None even at 44, only a hint. And then we can see the leading edge of the dye in the arterioles at about 1 minute. In a sense it was delayed ocular circulation. And the whole of the retinal vasculature was filled up only at about 3 minutes. We thought of, being a young patient, we thought of investigating him for other parameters as well, but nothing was forthcoming even with that. So we were really at a loss to know what's going on in this young patient. So whether it was migraine, though there was no history of migraine, there are reports in the literature that says that retinal arterial vasospasm, even in the absence of definitive symptoms of migraine, can be causative of such a picture in the young. Whether it was ocular ischemic syndrome, again, to explain OIS in a young patient without any other findings was hard. So we really don't know what's going on in this patient. He came back about a year later for a follow-up. His his fundus picture was a lot better with a better defined foveal reflex, and those whitish-looking lesions, ischemic-looking retina was not there. But he continues to have delayed ocular circulation even now. So we don't know what that is. I would like your inputs on that. Probably again. This is the last patient. This is an interesting angiographic phenomena that we noticed in this patient. He happens to be a 51-year-old gentleman who came with sudden blurring of vision in the left eye of 1 week duration. There was no other significant past ocular history, but he was a diabetic and hypertensive for the last 7 years on treatment. And his vision was 6/18 and 10. An anterior segment was normal, pressures were normal, and the fundus examination revealed a fundus picture like this, CRVO-like picture with whitening above and nasal to the fovea, probably suggestive of an element of ischemia there. What's the diagnosis would be a mischievous question for this audience, but is there a cilioretinal artery occlusion in this patient? He does have a cilioretinal artery here, and this seems to be along the cilioretinal artery. We did a fluorescein angiogram. Please disregard the dark shadows; those were unfortunately artifacts at that time in my camera. You can see that the retinal arteries have started to fill up, but the cilioretinal artery which is there is still not filling up. It ought to have filled up because it fills up earlier from the choroidal circulation, but it's not filled up. There is a hint of the cilioretinal artery getting some dye at about 34 seconds. I have put full frame photographs to draw your attention to this interesting phenomena which we noticed. The dye has gone back at 35, there is no dye. It's back in again at 36, and then in the subsequent frames it's gone. So this stuttered blood flow in the cilioretinal artery, and then it probably filled up fully only at about 1 minute 11 seconds in a stuttered manner. Late disc staining, of course, related to CRVO. So the diagnosis was a non-ischemic CRVO with impaired cilioretinal artery blood. When I looked up the literature, we got some useful insights into this. All other systemic investigations were normal. It's not a focal blockade because after resolution of this cilioretinal artery impaired blood flow, these patients have been subjected to nerve fiber layer analysis and visual field analysis. There's been no residual scotoma or retinal nerve fiber layer thinning. So here it proposes that there's no focal blockade that may occur, that does occur in these patients, contrary to what may happen in patients with AION, where there is a focal blockade. It is the increased venous pressure associated with CRVO against which the cilioretinal artery is pumping that causes the stuttered blood flow. And in this regard, it would be useful to note that the cilioretinal artery pressure has been estimated to be about 55 millimeters of mercury, and the pre-laminar CRV pressure here is about 62. The post-laminar CRV pressure is just about 10. So as it is even in the normal state, the cilioretinal artery is kind of pumping uphill. And in this situation where there is increased backflow due to a CRV, it has further more pressure to counter. Add to that the respiratory swing, what has been called as the respiratory swing. The blood pressure decreases during inspiration and then increases during expiration naturally. So these factors may all be acting in concert to cause that stuttered blood flow which we saw in this patient. About 8 months down the line, his fundus findings had resolved reasonably well, and there was nothing nothing in the fundus left to say that the patient had a permanent cilioretinal artery occlusion. So this was an angiographic curiosity which I thought I will show you. Thank you so much for your patient hearing.